Excellent. Good morning. Oh, all right. I like that. Welcome to our second session of this year's Palliative Care and Geriatrics Grand Rounds. I'm Beera Dobman, the course director. Welcome to everyone here in the Ether Dome, to everyone at Dana-Farber, at Care Dimensions, and Cooley Dickinson. It's my honor today to introduce Dr. Jordan Tishler as our speaker. Jordan is a cannabis specialist. Through his training in internal medicine and years of practice as an emergency physician, Dr. Tishler brings his knowledge, reason, and caring to patients at his company Inhale MD, and through his advocacy work at the local and national levels. Dr. Tishler graduated from both Harvard College and Harvard Medical School, trained at Brigham and Women's Hospital, and is faculty at both Brigham and Women's Hospital and Harvard Medical School. He has spent many years working with the underserved, particularly our veterans. And having treated countless patients harmed by alcohol and drugs, his observation that he had never seen a cannabis overdose led Dr. Tishler to delve deeply into the science of cannabis safety and treatment. Dr. Tishler is a frequent speaker and an author on a variety of topics related to the medical applications of cannabis. He is the president of the Association of Cannabis Specialists and the treasurer and board of directors member of Doctors for Cannabis Regulation. Please join me in welcoming Dr. Tishler.
Thank you all, and thank you for coming. Can you hear me adequately? Yes, great. It's always a little unusual to hear somebody read your bio and think, wow, I guess I wrote that, didn't I? But yeah, all right. And thank you for all of you who are in TV land. So I want to talk to you guys a little bit about medical cannabis. And I'm trying to, keep this kind of practical for you guys. The first thing I want to do is just tell you a little bit about myself. Not going to go over what she just said so much, but really to basically try to help you understand that having delved into this field of cannabis medicine, it's not entirely that I've just lost my mind. But really, it was my experience at the VA for all of those years in seeing so many veterans whose lives were dramatically harmed by various substances, alcohol being first and foremost by a large margin. That did lead me to that aha moment in which I said, why am I not seeing more harm from cannabis? And then around 2011, when the state of Massachusetts started to entertain this idea of cannabis as potentially therapeutically beneficial, I thought, maybe I better learn something about this. And so I started doing my homework, as all of you would do. And after a couple of years of really diving deeply into the medical literature, which of course everybody says there isn't any of, but that's not accurate. We'll get back to that. I came away being reasonably convinced. You can imagine I went in fairly skeptical and came out thinking that, you know what? Under the right circumstance, for the right patient, in the right manner, this stuff can be helpful. And then I looked around at my colleagues and folks at the esteemed institutions and thought, you know what? Most people don't know this stuff. And furthermore, for very good reasons, our major medical institutions really can't get into this. And there are a lot of legal and financial reasons for that. And that led me to start my private practice in Inhale MD. I certainly never really thought I would be in private practice, but what this did was it allowed me to bring this medicine to patients outside of these major systems and to be able to come back like I am today to talk to you all and help you understand and also hopefully work with you to co-manage some of these patients. And then looking around the environment further to see, who was out there doing this sort of thing. Unfortunately, I was somewhat dismayed to find that many of our colleagues were not taking a particularly medical or serious approach to this. And there are some historical antecedents of that we'll talk about, but this led me, as mentioned, to form this Association of Cannabis Specialists, which is really has sort of three missions, one of which is educating folks, medical folks, one of which is helping the lawmakers in Washington understand what value this has and what we need in order to be able to take care of patients properly. And the third is to work with the cannabis industry to try and help them understand how to make their products and their dispensaries more medical and more conducive to patient care. A quick mention that I do sit as a scientific advisor on the boards of two companies that work on making more medical-oriented vaporization devices. So far, at least in terms of reward to me, that's led to a bunch of worthless paper. Thank you for the laugh. A little bit of history here. Cannabis has been around for thousands and probably tens or hundreds of thousands of years, though we weren't around to know it. And that's an interesting little fact. It is something that gets brought up by the cannabis enthusiasts frequently as a justification for medical use. And while it's an interesting fact, I don't know that I think it's all that germane insofar as our modern medical understandings have not looked at cannabis over those thousands of years, and thousands of years of use in various non-rigorous settings probably don't inform us tremendously. It's important to understand that cannabis only became illegal in the United States in 1937, and did so not for any medical or scientific reason, but rather was banned as an agricultural product for reasons that had to do with protecting the paper barons who had large investments in southern hardwood forests, and as well as to make life yet harder for people of color who could grow cannabis, or more importantly, industrial hemp, on very small and not terribly arable pieces of land in the South and make a living. And in this country, we can't have that. The FDA only got involved in the prohibition in 1970 because in 1969, Timothy Leary won a Supreme Court case that invalidated the 1937 Marijuana Tax Act. And within 2 months, Richard Nixon had installed the Controlled Substances Act and installed cannabis along with a number of other things, including LSD, into Schedule I without any scientific reference. And we have him on tape saying that it was quite a political maneuver. And there it has remained despite pretty much a challenge every 2 years since 1970. Worth knowing that there are a lot of studies on cannabis, greater than 26,000. Should you wish to plug the word cannabis into PubMed. Now, we have to understand that not all of those are great studies. And for the longest period of time, those studies were only funded if their mission was to find harm. That is changing. But the point is that anyone who says, oh, there isn't any data, isn't paying attention, or they have a political agenda. An interesting study done in the UK in 2012 looked at their Controlled Substances Act and tried to use the then available data to rank substances in order of harms and where they then should fall on their Controlled Substances Act. And what they found was that cannabis, when assessed for risk, fell below alcohol and tobacco, which, as we know, are readily available. You guys have probably started to hear about the endocannabinoid system. I don't intend for anybody to get too much out of this slide, except to say, look, this is not the end of the story, but it's a good beginning. The fact is that we have a pretty good understanding of how the endocannabinoids are manufactured, how they're degraded, how they're used, and how they signal. So that we have complex signaling pathways. There are both receptor, there's a CB1 and CB2, which I find really reflect a lot of imagination in naming. But there are other cannabinoid receptors like the GPR55 and TRPV1, which play interesting roles in the signaling, as well as being important because they cross over into other signaling pathways. And then there are non-mediated, receptor-mediated pathways involved, for example, in the influence of cannabidiol on fatty acid amide hydrolase and other of the enzymes that are important in the breakdown of our endocannabinoids. Moving onward. So as you can see, I really didn't want you to get too much out of those pathways. I always put this slide toward the front because I want to address objections quickly. The question is, but isn't it addictive? And my response to that is sort of to make 2 points. The first is that while addiction for some reason rolls off our tongue very easily, and so we use that word commonly, it isn't really the right word. And it is important for us to understand that there is a difference between dependence, right, which is a physiological process wherein the body habituates to a particular substance, and then if you stop that substance, you may have withdrawal symptoms. That's different from an addiction, which I tend to relate as a set of maladaptive behaviors related to substance use. We do see some amount of biological dependence form with cannabis use, but what we don't see much of is the kind of maladaptive behaviors that we might see with other substances like spousal abuse or robbing liquor stores to get money for your habit. This is not to say, however, that this does not happen. It certainly does. It's also important for us to understand what are the ramifications here of both the withdrawal and the addiction. And so what we know is that when we think of withdrawal, we tend to have an image of people huddled in the corner, vomiting, sweating, screaming at the top of their lungs, which may be true for opioid withdrawal in certain very extreme circumstances, but it is certainly not typical of cannabis withdrawal. Cannabis withdrawal tends to be about 3 to 7 days of symptoms characterized by irritability and often insomnia. It's also important for us to think about these potential risks in the context of other substances that we are either forced to deal with or in fact prescribe. So the lifetime dependence for a cannabis tends to be around 9%, although more recent numbers make it look around 7%. Just for comparison, right out of the box, how many of us can't get started in the morning without a cup of coffee? Show of hands. Coffee, anyone? Yeah. So the dependence rate for caffeine is that same 7%. Compared to other substances, nicotine, as we know, is the most addictive substance at 32%. Opioids in general, 23%. That includes not just heroin, but all opioids. Which I always find an interesting statistic, because if you read the lay press, you get the sense that if anyone were to prescribe, oxycodone for somebody, within 3 days, everybody's completely addicted. And of course, this shows us that only 1 in 4 are likely to have a problem. Cocaine, 17%. That's the same 17% for our friends, the benzos, that we use with caution, but frequently, and 15% for alcohol. What does this mean to me? What this means to me is that we have a lot of substances out there that have potential for trouble, and we avoid the ones we can avoid, and we use the ones we need to use, and I think that that's probably a pretty good model for how we should think about cannabis. Types of symptoms that we can treat well with cannabis. Well, you guys have probably heard a lot about pain control. Certainly, in the context of this opioid crisis that we are in, that's getting a lot of discussion. And as you all well know, our choices for pain control management are pretty limited, right? I mean, we've got Tylenol, right, which lives in a class by itself, and then we've got all the non-steroidals, which come with their sets of issues. And if for any reason a patient can't tolerate or doesn't get benefit from those 2 categories, we're pretty much left with opioids. We can start to put in gabapentinoids maybe, but our hands are reasonably tied. So bringing cannabis to the table gives us another option. There's a lot of discussion about what sorts of pain may be adequately treated by cannabis, and so there's a lot of discussion about neuropathic type pains in particular. I have to say that in my practice, I have not seen a significant distinction between neuropathic type pains and other types of pain. For example, people with ordinary osteoarthritis seem to get significant benefit from cannabis treatment. Depression and anxiety is one that comes up a lot, particularly in the context of palliative care, and it's one that is more controversial at the moment in the world of cannabis medicine. But one of the things that's very interesting about the literature around this is that because of the complications, shall we say, around doing the kinds of studies that we all would expect from the political and legal issues, these studies are often done in a very observational fashion where it's BYOC, right? So we have no real control over what type of cannabis or what dose or frequency or those sorts of things that are used by the patients in these studies. One of the things that we've come to realize is that for the treatment of these two particular illnesses, dose is everything. And timing is important also. And so that a little goes a long way and a lot can be entirely counterproductive. And these studies generally, until recently, have not been able to demonstrate that because there's really no idea of what is going on in the study population. So what we've learned is that cannabis at low doses, particularly with dosed at night, can be helpful for both depression and anxiety, and do not require being intoxicated throughout the next day. And I think that's an important point. Unfortunately, in the cannabis enthusiast world, their view of things is slightly different and tends to lead to what I think we would all consider to be overuse under these circumstances. Insomnia. Insomnia often goes hand in hand with anxiety and depression, also with pain. But I think that if we were to sit back and say, what does cannabis treat the best out of everything? This would be it. Which is not to say that it isn't great for pain. I think pain is number two. But insomnia turns out to be, it's sort of under-discussed national epidemic as well. It is the number 2 complaint that patients present to general practices with, and we don't have a lot of good options for them either, meaning just as we don't for pain. Again, small doses around bedtime can be very helpful, and the route of administration is very important, and we'll come back to that. Anorexia. Now, certainly we've heard a lot about that because chemo-induced anorexia is probably the thing that cannabis is best known for. It's important for us to take a moment and remember that anorexia as a general term does not apply to anorexia nervosa, which is a psychological condition for which cannabis is actually a very bad idea. But anorexia associated with chemotherapy or other debilitating illnesses, cannabis can be extremely helpful. And again, the way in which we apply it, looking for the lowest dose and specific timing is crucial. Nausea and vomiting basically fits in that same category, right? In head-to-head studies, well, let's step back a second. In the late 80s, along came Marinol, right, which was intended to help with anorexia, nausea, and vomiting associated with chemotherapy. And it was particularly prescribed in the cases of women who were receiving treatment for breast cancer, and very quickly fell out of favor. It's still around, it's still used, but it isn't used much. And generally the reason for that is because what Marinol is a synthetic but pure THC, tetrahydrocannabinol, one of the cannabinoids in cannabis. But what we've learned is that cannabis is a complex mixture of cannabinoids as well as other chemicals called terpenes, which work together to create the expected result. And so with Marinol, which only had one of these, we didn't get the expected results. And in general, what people reported to us was that they got too intoxicated at too low a dose to derive the benefit, right? Essentially, they got blitzed and it was uncomfortable and they didn't want to take it. So that kind of got shelved for a while. And then in the early 90s, good old ondansetron came in. And quite frankly, in head-to-head trials, ondansetron is better than cannabis. However, it doesn't work for everybody all the time. And so it's nice to have something else that we can use. And it's also nice that cannabis and Zofran play nice together. There are no contraindications and you can use them together. I'm not going to spend a lot of time on this, but cannabis has barely been discussed with regard to sexual dysfunction. But as we know in palliative care, sexuality is a very important part of humans' needs and self-identification, and often gets harmed by serious chronic illness and often not well discussed in our care. Unfortunately, particularly for women, but also for men, we have really not much to offer by the way of medical treatment, and cannabis opens that up in a very powerful and useful way. And I think I'll leave that there. There are a couple of types of illnesses that are worth mentioning. Neurologic illnesses, this is obviously a very broad category. We've seen a fair amount of research in MS and ALS looking at not only pain control, but spasticity control, where cannabis has been shown to be very helpful. Soon to market will be a THC CBD medication from the same guys who brought us Epidiolex this past summer, which will be called Sativex, and a lot of the research on this comes from them. There's also some discussion now that's really only preclinical about using cannabis or pieces of cannabis as a neuroprotectant in neurodegenerative diseases like Alzheimer's type dementia and similar. And I think that's very exciting. It's pretty early at this point to start talking about it seriously, but it's something to keep our eye on. Autoimmune diseases like Crohn's disease or rheumatoid arthritis, there's a fair literature in Crohn's in particular showing that both THC and CBD as well as whole cannabis extracts can be helpful to downregulate this process. And what's even more interesting to me is that the most recent literature looks at using THCA, which is the acid form of tetrahydrocannabinol, which is also the precursor of THC, and it is non-psychoactive, meaning it doesn't cause intoxication, and it is about 10 to 20 times more potent as an anti-inflammatory than cannabidiol or CBD, which is clearly getting a lot of attention in the press and probably slightly unwarranted. So I have a number of patients with various autoimmune illnesses who have been benefiting from both cannabis itself and also from treatment with THCA as an addition. And then there's cancer. That's pretty much the big topic everybody wants to talk about. I think that we have to take a moment to really kind of break this down a little bit and understand that when we talk about using cannabis to treat cancer, we really have to divide this into two categories. There's sort of, in my mind, the relatively no-brainer category, which is symptoms of cancer. So whether we're talking about pain from the tumor itself or pain as a result of chemotherapy or radiation, or the nausea and vomiting, the anorexia that we talked about, the anxiety and depression, all of those symptoms, I think we can reasonably go after using cannabis in a cautious and thoughtful manner. But then there's the other category, which is the one that patients often want to talk to us about, which is, can cannabis cure cancer? And boy, is that a bugaboo, right? So You know, I think that we've got some very interesting, very preclinical data on this. Much of this is coming out of Israel, led by a physician named David Mary. And actually, he's going to be speaking at the Museum of Science, if you guys have a chance, on next Monday at 7 o'clock, and it's free. And I'm only plugging him because he's a great guy and he's doing interesting research. So, you know, what we know from studies like his are that THC, CBD independently, and whole plant extracts, meaning whole cannabis, do seem to kill cancer cells of particular types of cancers. Glioblastoma is one, hepatocellular is another that we have data on. But these studies have been done in cell culture, they've been done in murine models, and none of this has made it to human beings. At some point, I was sick and tired enough of hearing about how wonderfully cannabis was going to cure cancer based on these preclinical studies, that I actually went out and looked up what percentage of studies or medicines that look promising in animal models fail in human beings. Does anybody want to take a guess? Not hearing anything. Close. 92%. And you know, of course, that leads us to the question of why do animal studies at all? And I think that that's a valid question, but of course, you know, cell culture is not a substitute for an intact organism. So we have some methodologic issues there. All of which to say, it's very nice that we have the data that we have, and it's certainly not ready for prime time. So when I have this discussion with my patients, I present that information to them. And the flip side of that discussion is the fact that when used carefully, cannabis can be extremely, or is extremely non-toxic, right? It's famously reported that the cannabis enthusiasts say, no one's ever overdosed with cannabis. And that's not right. No one has ever fatally overdosed from cannabis, and that is true. And I've been involved in a number of autopsy series where people have been trying to prove that it isn't true, and frankly, we have yet to find a direct cause of death related to cannabis. But that doesn't mean you can't overdose, right? And we all know that overdose doesn't necessarily mean it kills you. It can do bad things to you. And in particular, it can make you extraordinarily uncomfortable. And with our patients, that's a bad thing, right? Because you only get one opportunity for first impression. And if that goes badly, you will never be able to get that patient to try it again. And quite frankly, that would cut them out of a whole lot of potential benefit. So when I sit with the patients, I say, look, this is relatively non-toxic. I will work with you on this, but it comes with an agreement. And the agreement is that you do not stop your conventional therapy unless your conventional doctors tell you that there's nothing left to do, right? And generally speaking, people respond well to that. I have had a few cases. I had one in particular that stands out to me of a 42-year-old woman, mother of 2 children under the age of 5, who was diagnosed with papillary carcinoma of the thyroid. And she did not want the curative surgical intervention. She wanted me to tell her that if I gave her some cannabis oil, everything would be fine. And needless to say, I did not say that. And I referred her back to Dr. Gawande, who was going to do her surgery. And she didn't come back to see me. Nonetheless, I want to talk briefly about strains and CBD, because these are the things that we hear so much about. Yes?
I knew you were going to get to this, but I think part of what's super helpful for us as an audience is even before we start thinking about the different strains, about all this literature is really helpful for us. And so I'm just trying to make sure we're going to get to that, about literature for pain, for nausea, in all these settings, because it really helps us to be able to understand how to think about this for our patients.
That's a perfectly reasonable question. I have organized these slides less around particular studies. And at the last slide, I give you a bibliography that you can go to. I don't know whether, I hope that will be helpful.
I think it would be super helpful for us just as we're going through to understand what is helping you be able to make with confidence recommendations to patients from the literature, because it just helps us. We're wanting to do what's best for our patients, and you have a knowledge and experience that is why we have you here, and it's also helpful for us to understand that. So it would be great if there are specific studies you could weave in as we're talking about. So to the extent you can, that would be great.
Yeah, I think I'm less prepared to do that than I might have otherwise been, but I will stop here and say that the very best, most useful summary of the state of the data was the National Academy of Science, Engineering, and Medicine report from January of 2017. Now, this is a truly seminal and voluminous piece of work. It's over 400 pages long, but I don't think you need to read it all because there's a lovely executive summary at the beginning of it that really gives us what you're talking about. Some of the way in which I've structured the talk really is to try and hit some of the key points that the patients are going to ask and that are driven by so much of the lay literature, which I think has put us in somewhat of an awkward position of having to respond to stuff that that the patients are going to bring us without it being well studied. So when I say that strains have no significant medical differences, I think that that is a much broader statement than will ultimately turn out to be true. One of the issues, to your point, is that we haven't really gotten to doing the kinds of studies that you would like. We would like to know whether OG Kush is better for pain than strawberry cough. Well, ultimately, I hope we get past those goofy names and into something that is much more a measured list of the cannabinoids in these various strains. But the point is that right at this point, we are only able to look at observational data that looks at what do people report when they use these things. And as you can imagine, that's definitely a biased data set. So this statement is really based on my own clinical experience that says that 90% of my patients, when confronted with various strains, cannot really tell the difference in terms of medical outcome. That isn't to say, however, that they don't develop preferences for how they might feel when using these strains, but that those preferences do not directly translate into things that we would consider a medical outcome. Cannabidiol, which is one of the many cannabinoids, is getting an amazing amount of attention right now. I think its primary attraction is the fact that it's non-psychoactive. It doesn't cause any intoxication. To me, that's not a particularly persuasive argument. And what is interesting is that lab studies show on the viability of CBD as a medicine fall into a number of categories. For example, we have evidence in human beings for CBD as an anxiolytic. And actually it works pretty well. But the kicker is that we need to use doses that are astoundingly high. So we're looking at 10 to 20 milligrams per kilogram, right? So if we imagine that imaginary average human being at 60 kilos, then we're looking at 600 to 1200 milligrams per day of CBD, which frankly you'd be hard-pressed to be able to find, let alone afford at a nickel per milligram. That works out to $50 to $100 per day. We have evidence of CBD as an anti-inflammatory in mice, not in humans. Again, that works out in the 5 to 10 milligrams per kilogram range. which is sort of similarly unavailable and unaffordable. There's also some evidence for using CBD for protection in patients who may have a propensity to psychotic disorders or who may have schizophrenia. And that's actually very interesting literature, but again, looking at that 10 to 20 milligrams per kilogram range, which means that all the discussion of CBD out there from your patients, from the lay press, from the enthusiasts, where they are puffing on a little CBD vape pen and taking in 10, 20, 40 milligrams of CBD, that's not a meaningful intervention. And to me, what that says is that there are a lot of people out there benefiting from this as a placebo, and an expensive one at that. This probably doesn't require a lot of discussion with you guys. Some of these slides were aimed at more lay audiences, but the goal is not to certify patients, right? Any more than it is to sit down with a patient and say, here's your prescription for lisinopril, see you later, right? Our goal is to take care of patients in a safe, effective manner, and this requires, close, careful monitoring, as well as a significant effort on our part to properly educate our patients on how to take care of themselves using this medication, and also to understand that the dispensaries are not a reliable source of that information for patients. I can't emphasize this enough. The people behind the counter at the dispensaries at best are stoners. You know, their primary qualification for that job is, yeah, man, I like weed too. That does not, they are not pharmacists, they are not pharmacist techs, they do not understand medicine, even if they do think they understand something about cannabis. And then we also have to remember that because we don't, at this point, write prescriptions in the truest sense of them, we cannot control their behavior, their dispensing behavior. And as a result, there's a lot of upselling and side selling that ultimately leads to harm to our patients. And so we really need to understand that. I'm working hard as an advocate to try to change some of that and make the medical system more medical in that regard. But right now we have what we have, which provides access, but not a lot of control. And so I spend a fair amount of time with my patients, not only addressing the how-to, but also what not to do and how to, to expect this kind of sales pressure and how to respond to it effectively. One of the things that's really important about cannabis medicine that's slightly different from the way we think about conventional medicines is that the route of administration makes a huge difference. Now, certainly when we think about taking oral Lasix versus IV Lasix, that's different, right? And we calculate for those differently. And the time to onset and the expected effect are different. And that's true with cannabis as well. So that the common understanding that, well, if you don't want to smoke this stuff, you can just have a cupcake, is not really accurate. Nor is that good medicine on many other levels. So the route of administration along with the dosing really is very important. Obviously, we're all aware that this stuff can be smoked. I don't recommend that we recommend to anybody smoking this stuff. Although what's very important for us to also understand is that there are a number of good studies on the effect of smoking on the pulmonary system, particularly looking for COPD and cancer, and we're not finding it. And in fact, a week or so, 10 days ago, there was a review article that looked at a range of these things. And yes, we can generate some chronic bronchitis that resolves if smoking is stopped. But other than that, we do not see the development of COPD, and we do not see pulmonary cancers arise. And the data set for this is now about 40 some odd years old. So while it can be argued that cannabis has been changing over that period of time, it's a reasonable length of study. Nonetheless, I think it is reasonable for us to advise patients to avoid smoking. Why? So Smoking, if we think about it, is a form of inhalation, and inhalation as a method of administration has a number of advantages. As we're probably all aware, it's relatively rapid in its onset, right? Out there in the world, you'll see people say it's instant, and that's not true, and it's important for us to understand that it's not true because it does take about 10 to 15 minutes to work, and if we don't warn our patients, they can inhale an awful lot too much in 15 minutes. So we need to set expectations appropriately when titrating this stuff. But it is quick so that, for example, when people have the acute onset of pain or they have breakthrough pain, inhaled cannabis can be a very effective method. The other thing to understand is that it has only a modest duration of action. It wears off after about 3 or 4 hours, kind of like an Advil. And in some circumstances, that's not advantageous, but in many, it is. For example, somebody who comes in or who develops a migraine at 8 o'clock in the morning may take some cannabis by inhalation, feel better by noon, and be able to go about his or her day for the rest of the afternoon. So if we want those sorts of advantages and we don't want smoking, then vaporization is the approach. Now, there are a number of different types of vaporizers that I want you to be aware of, but loosely, there are the machines like this one, which are cannabis flower vaporizer. Flower is the part of the plant, right? The flower of the plant. We used to call this weed, right? But it's important to understand it's the flower of the plant, it's not the stems and leaves, etc. So with this machine, you grind up the cannabis material, you put it inside the machine, it's set to a specific temperature, at which point the medicines that we want volatilize so that we can inhale them, but it is a low enough temperature that we do not cause products of combustion, right? And the number is 350. Just like we were making cookies. Turns out that that's the perfect temperature for vaporization, and that at about 400 now we start to get into benzene and other products of combustion that we'd like to avoid. It's also worth knowing that the world has gotten very interested in these little pen-shaped vaporizers, and I think that that's a bad idea, okay? They definitely win hands down in the sexy factor, in the discreteness factor, and even in the ease of use factor. This machine, you have to put the cannabis in it, you have to close it up, etc., and wait till it heats up. These things, you put them in your mouth and you inhale and you're off to the races. But the issue here is a technological one. This cannabis oil cartridge can contain additives like propylene glycol or polyethylene glycol to dilute the cannabis and make it work, that when heated turn into formaldehyde, which is something obviously we don't want. The industry has moved away from PG and PEG and started using cannabis-derived terpenes. Again, these are the aroma molecules in cannabis, but they also are thought to be biologically active. So many questions arise. Well, if a little is good biologically, how do we know that a lot is okay? But the other thing is that at relatively low temperatures, at about 425 to 450, these terpenes devolve into acrolein and metacrolein, which are carcinogens. So the problem, again, is not necessarily that they could become carcinogenic, but that we can't control the temperature, because these devices are simply a battery and a heating coil. And so they really have no sophistication, and we have no idea what the temperature is at that heating coil, particularly after a few puffs where the temperature can rise and rise. So I tend to avoid these machines and suggest those sorts of machines. Cannabis taken by mouth behaves pretty much 180 degrees opposite of inhaled. Where inhaled is quick and relatively short, the oral stuff takes a long time to work, right? An hour, could be 2 hours, could be even longer than that in some rare circumstances, but usually between an hour and 2, we have the onset of effect. But the plus side is that because the cannabis, and particularly the delta-9 THC, is modified through the first pass effect in the liver into 11-hydroxy THC, it behaves differently. It's a different medicine at that point, and it has a much longer duration of action, more like 8 to 12 hours. So in many instances, the way I look at this is when we were taught how to use various forms of opioids for pain control, with long-acting opioids used for basal control and shorter-acting opioids used for breakthrough pain, these guys make a similar model. You can use twice or occasionally three times daily oral medication to achieve that long baseline control, and then vaporized as a means of treating breakthrough pain. There are a number of other routes of administration that I briefly want to touch on. Tinctures are a liquid extract that people, for some reason, are very excited about. I personally don't see the attraction to putting things under the tongue, but patients love this idea. What's interesting, however, is that when we do bioavailability studies, we see that because cannabinoids are very hydrophobic, there is almost no sublingual absorption, and that in fact, what people get is a sort of Pavlovian response, that they put this stuff under their tongue and they get a feeling that they expect. And then, of course, nobody ever spits this stuff out. They simply swallow it. And then, of course, we're back into the PO version of this, at which point it kicks in as expected within an hour or two. I use tinctures in particular with patients, for example, if they have G or J tubes or otherwise cannot tolerate something oral, but essentially they are liquid oral. And then topical stuff, I think, attracts a lot of attention. It would certainly be nice if we could tell our patients who have OA knee pain that they can go and get a cannabis cream and rub it on their knee and they'll be better. But what we know is, again, because of the hydrophobic nature of cannabinoids, they do not go through skin. And so while topicals may be useful for some dermatologic conditions like eczema, they really have been shown to provide no benefit above and beyond placebo benefit to deep structures like knees. This is probably not a big surprise to anybody here, but dose matters, right? As with all medicines, there is a sweet spot, a point at which we get maximal benefit and beyond which we do not get increased benefit, but we get increasing side effects. And this is clearly the case with cannabis. Most of my patients get their benefit in this sort of 10 to 15 milligram range, occasionally at 5 milligrams and occasionally at 20, but really this is the average. And when I talk to colleagues in the cannabis world, they often fall out of their chair when I tell them this, because they're used to people reporting benefit from smoking, you know, joints that contain hundreds of milligrams. And I think that that's something that we want to avoid for our patients. So essentially, something controlled like this is the idea, and we really are not trying to tell grandma to go off and do bong rips. So to summarize, somewhere around here it says summary, prohibition was largely financial and political. We have now some very good safety data, as well as data for effective use of treatment of pain. It can be effective, we think, or there's growing evidence for neurologic and immunologic illnesses as a neuroprotectant and immunomodulator. Certainly, they benefit from the pain control. The routes of administration make a huge difference, and we don't know that strains make much of a difference at this point. And I've kind of mentioned the association of cannabis specialists. I just wanted to bring it up one more time for you guys. And then I'm going to, there's the URL so you guys can look. And here are the references that I mentioned. And I would stop here and entertain questions, because I imagine that there are a lot of them. Thank you.
Thank you for such an enlightening talk, Dr. Tishler. I'll start with a question. I've had a couple patients who've had great success for cancer-related pain with starting cannabis and have come back to me after initiating it and stopped all of their opioids, which I guess is a good problem to have, but I'm wondering, how often do you see cannabis as a supplement or an adjuvant to opioids, or how often do you see patients self-down titrating?
Excuse me. Yeah, a lot. Whether we're talking about cannabis pain or other forms of pain where opioids have been instituted, many of the patients come to me saying either the opioids aren't enough, or they're being cut back, or they wish they could cut back, or those all sorts of motivations. And so if we start them on cannabis, what I have found is that many, not all, can decrease their opioids, and even in some cases down to zero. What I generally tell them is, look, we're going to start you on cannabis at this low dose. We're going to work up until we have pain control. And if you need your opioids, take your opioids, right? But start with the cannabis because it's safer. So what happens is that as we titrate the cannabis into the right range, the opioids sort of become less relevant. And because we do this slowly and taper off the opioids slowly, we end up with an effective wean. It doesn't work for everybody. And also, it's not a static situation. I've had patients be able to wean off opioids for a period of time and then need to reinstitute them down the line when things worsened. So the way I look at it is, this is not a competition, really. This is another tool in our arsenal, one that we have some pretty good safety data on, and one that gives us opportunities for better patient care where our hands are otherwise more tied.
Great. Other questions?
Hi. Can you talk about relative and absolute contraindications for this one? Because I think, again, there are some higher doses can cause ischemia too. Like people can get angina or ischemic heart disease. And also, I think asthma and people with bronchospasm, they can have triggered that too. So again, I want to hear from you also. Thanks.
So did everybody hear the question? So he wanted me to speak about relative contraindications or absolute contraindications to using cannabis. And he specifically brought up issues around cardiology and whether there's some increased risk of MI, and also when people with asthma or other forms of bronchospasm. There are a number of things that I think of as relative or absolute contraindications, neither of which are the two that you mentioned. So let me start by saying there is some literature about the association of cannabis use with angina or MI, but it's so mixed and so observational at this point that I think it's hard to make much of it. So in my elderly, which is most of them, patients who have coronary disease, I bring this up, and it's one of these monitor closely situations. I have yet to have any of these patients report back to me any uptick in their anginal symptoms, and I have not become aware of any of them landing in the ER or worse as a result. What the feedback mechanism for my becoming aware of that, that's a good question. There's also some data in the cardiological literature about its provoking or worsening AFib. And I think that looks fairly real, but the incidence is low, and most of my patients either haven't AFib or they have it. And if they're in AFib and properly anticoagulated, then I'm probably not making them any worse. And then there's the literature around whether it can worsen congestive heart failure. Again, data there, very observational and spotty, hard to know what to make of. I have had patients come to me with ejection fractions of 15 to 20% and have scratched my head about that and talked with their cardiologists. And the consensus that we've come to has been that the patient's symptoms leading to the discussion of cannabis have been sufficiently concerning that the cardiologist agrees that we should proceed. And again, we watch carefully. And I think that, if there were a take-home message here, It's that just like any other medication, I mean, you wouldn't start somebody on hydrochlorothiazide without checking their potassium, right? This is a medicine that has potential consequences, and we need to follow our patients closely. And we need to get past this weird idea that we went from, my God, this is going to kill you, it's the devil's lettuce, to it's meaningless and harmless, and you know, it's a vitamin, it should be in the water. And by the way, I've had people literally say that to me. One of the things to understand, and we've touched on this, is that cannabis is a mixture of a whole bunch of cannabinoids and other chemicals, which we need. But some of them do some things and some of them do other things. And one of the things we know is that CBD, which again is getting a very rosy description at the moment, is the part that's most likely to interfere with conventional medications, particularly it's the 3A4 isoenzyme, the P450, which turns out to be fairly busy metabolizing conventional medications, whereas the isoenzyme that deals with THC is kind of lonely and can, you know, has capacity. So where this comes up is, you know, I think the people out there taking sort of placebo doses of CBD are probably okay. And they also tend to be the young folk who are not on a lot of medicines. But when I have my elderly folk come in and they say, somebody told me that I should be on CBD oil for my back pain, that's a discussion I want to have, because they tend to be on a lot of other medications, whether they're in a coagulation. CBD interferes with warfarin, for example, but not the 10As, interestingly enough. The one that really worries me is Plavix, right? In post-stent patients, if we shut down their stent, we've done a bad thing, right? Immunosuppressants, tacrolimus. Oddly enough, I've had a small cadre of people come to me for ordinary routine back pain who incidentally have had liver transplants. I'm like, what's the odds of that happening more than once? But I guess around here, not zero. In any case, I immediately envisioned a scenario in which this person went into a dispensary and they said, what are you here for? And he says, back pain. And they say, oh, you should megadose on CBD. And I'm thinking that could be lethal because their tacrolimus level could go through the roof. So a lot of discussion needs to happen around that. I think that so far the best literature for worrying, we're about to have an orthopedic moment, I'm afraid. The best literature for worrying about this stuff is around drug-drug interaction. And to let you all in on a secret, WebMD, oddly enough, has a really good interaction checker that at least contains cannabis. It doesn't yet contain cannabidiol, but it's a good place to start.
Great.
Sure.
I want to make sure we open it up for questions at our remote sites. And if not, we'll end with one final question.
Thank you so much for this covering this important topic. I'm actually a geriatrician and palliative medicine doctor with BI and Hebrew Senior Life. I wanted to just a couple of things. I have about 30 seniors who I have trying cannabis for chronic pain in particular. And can you comment what your experience is with the dosing for the very old? These are people in their 90s. I've had a hard time with the narcotics and constipation issues, so I've had some good results. It may be placebo effect, it's hard to know, but quite a few of these folks benefit from even just 1 milligram, 2 milligram. Often I've had issues with using the cannabis in the chocolate because then they take too much by mistake. And so I've had them do the tincture, but more for ingestion, not for absorption under the tongue. Challenge with that too is they have arthritis, and squeezing the tincture onto, so we've squeezed onto crackers and ingested. That helps. The cracker's a good thing. So if you could, the other thing was I was concerned when I'm having them do like half of a square of chocolate is not evenly distributed within the square. So I feel like that could be a problem. And can you comment about, often I am having them do a mix of the CBD and the THC, but I hear your comments about CBD, so maybe that's not the best thing. But so maybe you can comment on some of those issues.
Yeah, Again, great questions. To my great honor, I have a lot of elderly patients. I really enjoy working with that group in particular, 80 to 90. I think my eldest is 97 or 8. So yeah, I have noticed that the super elderly, the nonagenarians, do often have more trouble with this medicine than the younger folk. But then again, as you point out, they have trouble with many of these medications, including the opioids. I think what you sounds like you're doing is great. Using the tincture is a very good way to get sort of single-digit dosing. 1 to 2 milligrams in anybody in this room, I would think would be completely ineffective. But again, in the 90-plus crowd, I would agree to start there, absolutely. I think that the idea of sublingual administration, as we talked about, is not in evidence, but as you described, the idea of dropping things under your tongue is a recipe for misdosing, right? So even with my young patients, I recommend that they dose it drop for drop onto a piece of bread or a cracker, maybe add a little butter to make it more palatable and also to increase the lipids for absorption. And then eat it. And I think that works really well, and I would do that twice a day as a starter. With my younger folks, I'll usually start them at 5 milligrams and work upward from there. We didn't really touch upon this, but the idea of, these large bars of chocolate or other, cupcake-oriented things, I don't think makes good medicine. Not only do we have the issues of whether things are properly distributed, but also we have to remember that our patients are more than just their need for cannabis or any other particular medicine, and that many of them are diabetic or obese or all those sorts of things, and adding a 250 calorie brownie twice a day into their diet is not practicing good medicine. The CBD aspect of what you asked, I think it's probably harmless. That is to say, all of these studies that I mentioned, which show that we need super doses, suggest that at least if we're taking these minute doses, it's probably not doing much anything. So I wouldn't worry much about that. To the extent that the CBD is expensive, I wouldn't point people towards adding additional CBD. But if you have somebody who's using a tincture or a gummy that's a 1-to-1, I think that's probably harmless. One of the things that's interesting is that I'm seeing this evolution of people talking about CBD-rich products more and more, which means that there's much more CBD than there is THC. And what I think is going on there, because their total ingestion of CBD is still minute, is essentially they're just using the CBD to dilute the THC and then getting the placebo effect. So my sense is that if you want a true effect, focus on the THC. And if what you need is a placebo effect, then you have a range of options there. So
we'll end there. Thank you very much, Dr. Tishler.
Great. Thank you.